Hi, my name is Natalie Garcia, and I'm a third-year medical student at UAB, and I want to thank you for taking the time to listen to my presentation. So my presentation is titled, A Deep Dive into Epidermolysis Bullosa Acquisita of the Esophagus. The learning objectives of this presentation are to recognize the pathology and sequelae of epidermolysis bullosa acquisita of the esophagus. And the second learning objective is to identify therapies aimed at treating epidermolysis bullosa acquisita, which is also coined EBA. So our patient presentation, our patient was a 62-year-old white man with a past medical history of NASH cirrhosis, status post-liver transplant, heart failure with reserved ejection fraction with an ejection fraction of 30 to 35%, chronic kidney disease stage 3 due to IgA nephropathy, blindness, and epidermolysis bullosa acquisita of the skin, which was diagnosed in 2019. In terms of a past workup, our patient had recently been hospitalized several times with dysphagia and anemia, with concern for gastrointestinal bleeding. Multiple previous esophagogastroduodenoscopies showed grade D esophagitis and strictures, which did not improve following dilation and a course of pantoprazole. On the admission at which we took care of this patient, he presented to the emergency department with coffee ground colored emesis. An EGD demonstrated sloughing of the proximal and mid-esophagus concerning for epidermolysis bullosa acquisita. In terms of diagnosing EBA, EBA is a rare adult-onset subepithelial mucocutaneous autoimmune blistering condition, and biopsy typically reveals antibodies against type 7 collagen, which leads to skin and mucosal fragility. The bullous lesions typically appear on areas of the skin after experiencing friction, such as the palms of the hands and the soles of the feet, or the esophagus after an EGD. So here are some pictures of an end of endoscopy, extensive epithelial sloughing, and the second picture also demonstrates epithelial sloughing during the endoscopy. So in terms of treatment for epidermolysis bullosa acquisita, the first-line treatment is typically immunosuppressive agents such as mycophenolate mofetil and dapsone. The second-line treatment for EBA is usually IVIG, which is beneficial for patients who are not candidates for further immunosuppression, such as our patient. And here are some pictures of the cutaneous manifestations of EBA, specifically in our patient. And you can see the bullous lesions on his scalp and on his hands, and also on his trunk. So in conclusion, given the rarity of EBA, esophageal mucosal erosions are often mislabeled as severe esophagitis when seen on EGD or a stricture which is dilated. And it's important to recognize that these are manifestations of EBA. Given treatment should be focused on the underlying disease to heal the esophageal mucosa and prevent further injury. A take-home point from this presentation is that it's important to consider the diagnosis of EBA esophagitis in patients who have a previous diagnosis of cutaneous epidermolysis bullosa acquisita and who are experiencing symptoms of dysphagia, reflux, and hematemesis. Thank you for taking the time to listen to this presentation today.